So somebody asked about the alternating Horner syndrome. And as you know, the Horner's pathway is quite long. So the oculosympathetic pathway starts in the hypothalamus, descends posterolaterally in the brainstem, all the way down to the cord, to the C8-T2 level at the level of ciliospinal center of Budge, exits white rami as a second order neuron, this is the first order neuron, over the apex of your lung, up the sympathetic chain, passing without synapse through the inferior middle to the superior cervical ganglion. At this level of the superior cervical ganglion, synapse, that becomes the third order neuron, travels with the carotid by wrapping around the internal carotid artery, enters the skull, into the cavernous sinus, short course on 6 to 5 subdivision 1 to the target organ. So it should be just hypothalamus straight to the eye like this, but it isn't. It's this long pathway. And so if you have an alternating Horner syndrome, there's really very few places that can be because the pathways are so far apart everywhere else. So in the orbital portion, you'd have to have a bilateral lesion that alternates somehow and only involves the sympathetic pathway. So that would be a very hard thing to create that lesion. Likewise, the carotid artery, very far apart. So you'd have to have bilateral dissections. One would heal and then it would get to the other side. So this would be a hard thing to create with a structural lesion as well. Same with the apex of the lung. How could you get a lesion on the apex and then another lesion on the other apex and then it went away? So these are hard things to create. And so you're kind of getting the idea that the only way to get an alternating isolated Horner's, if it's something where the two things are very close together. And that means the cord or the brainstem. So normally alternating Horner syndrome occurs when you have the sympathetic pathway very close together, and that's going to be in the cord. So, and I guess you could make it a brainstem lesion or hypothalamic bilateral, but it's a lot less likely. So almost always these alternating Horner syndromes are central. They're first order neuron, and the most commonly classically described cause is a cervical spine lesion like a syrinx because it's central and so it can get both sides. You can make up lesions, bilateral orbit, bilateral carotid, bilateral orbital apex, bilateral cavernous sinus, but these are just so much less common. So where would I image? You would image the exact same area you would image the regular Horners, all the way from hypothalamus down to T2 in the chest. But if it's really an alternating Horners, pay particular attention to the cord and in particular syrinx.